segmental spinal. For this, I would like to invite Dr. A.L.Meenakshi Sundaram, sir, MBBS DA, MD, is a distinguished professor of anesthesiology and former dean and DME at several government medical colleges, including training Stanley Chennai. A respected leader in his field, he has served as National Vice President and Governing Council member of Indian Society of Anesthesiologists and has held key roles in the ISA Tamil Nadu state branch, including president and state secretary. So now, without much delay, I would like to hand over the session to you, sir. Please proceed with your talk.
Thank you, Lynette. At the outset, I request our branch president, Dr. Munian, to deliver his presidential address.
Good evening, all. Honorable moderator and esteemed colleagues and our fellow professionals and delegates. Welcome to our ISA Puthukkottai City branch. Every week we are conducting Puthukkottai Bhudhan for online webinar. Today we are conducting 14th episode of second editions. Today our speakers are going to discuss about the segmental spinal anesthesia. I am honored to address the critical role of segmental spinal anesthesia in modern surgical practice. As we continue to push the boundaries of medical innovations, segmental spinal anesthesia has emerged as a valuable technique, particularly for upper abdomen surgeries in complicated cases for general anesthesia. Benefits of the segmental anesthesia: it also provides post-operative reduced post-operative respiratory complications like pneumonia, atelectasis, and also early ambulation and reduced hospital stay. Patients receiving segmental spinal anesthesia tends to recover very faster when compared to spinal anesthesia, and also it provides a shorter duration of hospital stay. Hemodynamic stability. This technique provides excellent hemodynamic stability, which also minimizing the risk of postoperative, perioperative hypotension and bradycardia. And it also provides effective pain relief. Segmental spinal anesthesia offers effective pain relief. It also reduces the additional dose of analgesics. Key considerations for segmental spinal anesthesia, like patient selection, is a very crucial for the suitability of the segmental spinal anesthesia. Dose and site of injection. The dose of local anesthetics and the site of injection must be tailored to the specific needs of surgical procedures and the patient's needs. Monitoring and the anesthesia technique, close monitoring and precise technique are essential to improve the patient's outcome. Conclusions: segmental spinal anesthesia is a valuable technique for upper abdominal surgeries where GA is contraindicated, which also offers benefits like reduced hospital stay, effective pain relief, and also it also reduces post-operative respiratory complications. By reducing the advantages and consideration of this technique, we can provide optimal care for our patients and improve our surgical outcomes. Thank you, sir.
Thanks, Dr. Munian, President. Now I request Dr. Kannan, Secretary, to deliver his Secretary report.
Good evening, all. I am Dr. Kannan, Secretary ISA Puthukkottai branch. Successfully, we are conducting 14th Puthukkottai today. Today, our topic is segmental spinal anesthesia. This topic is very much interesting and routine for all practicing anesthesiologists. Welcome all our Indian speakers. I welcome all the participating delegates. Last 16th April, we have conducted 13th webinar of Puthukkottai smoothly. Last webinar topic was neurosurgery posterior fossa tumors. Our moderator was Dr. Manisha T. Kettigar, consultant, Bhudhan Institute of Neurosurgery, Solapur, Maharashtra. We have divided the topic neurosurgery into three. First one is CSO pathway and ICP monitoring. Second one is pathophysiology and presentation of posterior fossa tumors. Third one is anesthetic treatment of posterior fossa tumors. First subtopic, CSO pathway and ICP monitoring, was done by Dr. Murari Bharadwaj. He is Dean B. Resident of Main Hospital, Jharkhand. He has explained CSO pathway with introduction and basics of CSO production and composition with diagrams and flow charts. CSO pathway with clear pictures, intracranial pressure basics, ICP waveform components with specific graphs, Lundberg waves, ICP monitoring techniques, and clinical indication for ICP monitoring, interpretation with the clinical implications. Second subtopic is pathophysiology and presentation of posterior fossa tumors. This topic was done by Dr. Silora Sahu, senior consultant, Main Hospital, Jharkhand. She has started with the clinical scenario and clinical features which occurs in posterior fossa tumors. She has elaborated the symptoms such as headache, vision, difficulty in vomiting. She has covered the pathophysiology with the pictures very clearly. She has explained the complete anatomy of skull, clinical features in posterior fossa tumors, and investigations which we have to do. And third subtopic is anesthetic management in posterior fossa tumors surgeries. The topic was done by Dr. Amlan Swain, senior consultant, Dr. Hospital, and Dr. Amlan has started with the pre-operative concerns. In any case, we have to do pre-operative assessment and optimization. Anesthetic management, pre-operative and post-operative management. Pre-operative assessment includes history, clinical complete physical examination, and investigation. Goals of these topics are surgical access, neuromuscular monitoring, early neurological assessment to minimize the neural tissue trauma, to maintain respiratory and cardiovascular stability, to rule out life-threatening complications. He has explained the challenges we are going to manage in posterior fossa tumors, pre-operative evaluation, positioning of the patient, choice of anesthetic agent, monitoring, pre-operative care, post-operative elective ventilation, look out for complications, and preserving neural functions is a priority. Last webinar, 998 delegates attended. We need your continued support to continue this academic program successfully. Academic faculties, kindly encourage your postgraduate to attend our webinar continuously, which is very much informative to their exams. We thank our academic chairman, Dr. Meenakshi sir, for his kind support. We have reached our target of 1,000 delegates. We have fixed our next target of 1,500 delegates to attend the upcoming webinars. Thank you all.
Thank you, Secretary. Now it is my duty in the thematic address. I have to introduce the faculty. Today we have the topmost faculty available across the country in segmental spinal. As a youngest speaker, we have Dr. Geethavarshini, who is a final year MD in Mahatma Gandhi Medical College, and she is appreciated by her professor very much. And when I contacted her professor, he immediately recommended her name, and she has won. True to her credit, she has won Dr. M.T. Bhatia Young Physician National Award in 70th ISACON. And she has a publication in Journal of Clinical and Diagnostic Research in 2024. And even in undergraduation, she has scored distinction consistently in all the subjects. And she is interested in pain management. So she can make everyone's life painless. Why I am saying she is about to get married, so she will make her spouse life painless, and she is interested in critical care also, and she is interested in photography, and even in the young age she is interested in temple exploration. That is important, and she is reading novels as like any other young individual, and she is interested in walking. I don't know why she is walking. If she stands, the wind itself will take her to greater heights, and she is interested in throw ball. So the spouse can be even thrown. So we have to be very careful. And I thank Dr. Geethavarshini to be our faculty for Puducherry Bhudhan. And it will be followed by Dr. Shirish Mahure. Everyone knows that he is an associate professor of Panjabrao Deshmikh Memorial Medical College, Amravati, Maharashtra. He is a known pain physician. He is a known pain physician. And more than that, he is a ACLS instructor and a BLS instructor. When I wanted Dr. Naresh Paliwal to mention a name on segmental spinal to be a speaker, he immediately recommended his name. So the Dr. Shirish is that a popular person, and he is interested in cricket and swimming. So he is a good swimmer, So in anesthesiology is like swimming, because whether it is a butterfly stroke or backstroke or breaststroke, you have to reach the other shore safely. So anesthesia also, whether it is regional or GA or segmental spinal, you have to safeguard the patient. So he is a correct person to talk on that. It will be followed by the greatest person, Dr. Naresh Paliwal. If you say segmental spinal in the country, the first name will be Dr. Naresh Paliwal. So he is a professor emeritus. He is a faculty everywhere in state, zonal, and national. He will be the faculty in segmental spinal. He has more than 60 presentations in segmental spinal, and he has conducted many live workshops. Even day before yesterday only, he was coming from Agra, and he has to attend indoor. Then he is traveling across the country for these various workshops, and he has 6 publications in segmental spinal. And he has published an article on dex-keat combination, dexmedetomidine and ketamine, and he has published national and international journals, and even now today he has declared that his article is accepted for British Journal of Anesthesia. So that is a credit for Puducherry Bhudhan also. We are having such a well-known, renowned speaker, and he has won the best paper award in Mahatma, that is Maharashtra conference. He has published a handbook on segmental spinal, and he plays badminton, and he enjoys driving. More than that, he has convinced me several years to practice segmental spinal. But see, the old habits die hard. I used to tell him, when I am safe with my technique, why should I go for segmental spinal? But incidentally, when I had a 86-year-old lady with a treadmill positive, I have no other option for bilateral hypochondrial lipoma. Then I contacted him. Then he suggested me how to perform that, and successfully I have come out. So usually the telemedicine, I used to consult Dr. Makesh Vakamudi and Dr. Sunil Pandya, and he has become the third person. On that day, I contacted Dr. Parsardi also. So we have successfully come. Just because I have contacted these two, I have not disturbed Dr. Richa Chandra, our moderator. So what I want to convey, Dr. Naresh Paliwal is such a passionate person to push the technique across the minds of younger as well as older individuals like me. So we congratulate and thank him for accepting our invitation to be the speaker. So when such a great person is coming, then the moderator should be equally competent. Then we have found out that Dr. Richa Chandra, who hails Naresh Paliwal with a lot of honor and respect, and she is the known person across the country, like Dr. Naresh Paliwal, as a regional person, that is segmental spinal person, because Madam is a professor in Rohilkhand Medical College and Hospital, Bareily, UP. But Madam is practicing thoracic spinal since the year 2019. Whenever she talks, she will talk about segmental spinal only, and she thinks segmental spinal is the only method to anesthetize all the individuals. So that sort of a passion is running a WhatsApp group also to popularize that closed group. So since 2019, she is practicing that, and from 2019 to 2025, she has done more than 6,000 cases. Mind-boggling, because 1,000 cases per year. Again, as it is a 6 years tenure, she has done 6 research articles in that, and 2 review articles and 2 case reports. See, more than that, Madam has discovered so many new things. So even I said the Madam can conduct a discovery channel. So this is Richa's Carmen's technique. That is a double needle technique for spine fractures. And she has discovered another Richa's angle for ergonomics in MRM under segmental spinal. And even with all these greatest academic qualifications, she is traveling, interested in traveling. She is reading books. And Madam is a good speaker, but she is running an NGO organization for speechless people. So that is a contrary. When a good speaker is bothered about speechless people also. So with this introduction, I hand over the session to Dr. Richa Chandra to conduct the session. Thank you, madam.
Good evening, everyone. Thank you, sir. You've elaborated many things about segmental spinal anesthesia, and thank you again for the nice introduction. I am just going to start our today's session, and I am just going to welcome Dr. Geethavarshini, and she will be speaking about the drugs basically, which is needed for segmental spinal anesthesia, and her topic is baricity, specific gravity, and density. So now I'll invite Dr. Geethavarshini. Madam, please come and
Good
start your
evening.
topic.
Good evening, everyone. I would like to take this opportunity to thank everyone for this opportunity. Thank you, Dr. A.L.M. sir, for this very kind introduction and all the other organizing committee members. A special mention to Dr. Parthasarathi sir for guiding me throughout life and also through this presentation. My topic for today is density, specific gravity, and baricity. So, what is density? Density is defined as the mass per unit volume of the solution at a specific temperature. Density is a fundamental physical property that measures how much mass is contained within a given volume of a substance. That is, it is a measurement of how tightly a material is packed together. This image depicts three various density objects. First is the molecules where it's very tightly packed together, which is highly dense. And the third, which shows the molecules which are loosely packed, which is very low dense. Specific gravity. Specific gravity is the measure of the density of an object in comparison to that of density of water. For example, the density of mercury is 13.6 grams per cc. The density of water is 1. So 13.6 grams per cc divided by 1 will give us 13.6. So the specific gravity of mercury is 13.6. The density of CSF is 1.0003 gram per ml at 37 degrees Celsius. Then what do we mean by baricity? Baricity is the ratio of density of local anesthetic solution to the density of CSF. Baricity is the ratio comparing the density of two different solutions, whereas specific gravity is the density of a substance to the density of water. As we know, the classification of baricity is isobaric, hyperbaric, and hypobaric. To make a drug hyperbaric to CSF, it must be denser than CSF, which is with a baricity appreciably more than 1.003. The reverse is true for making a drug hyperbaric to the CSF. Dextrose and sterile water are commonly added to render the local anesthetic solution either hyperbaric or hyperbaric. When added dextrose, it becomes hyperbaric. When added sterile water, the local anesthetic solution becomes hyperbaric. This tabular column depicts the density of various local anesthetic solutions. The density of plain bupivacaine is 1.005. The density of hyperbaric bupivacaine is 1.022. The density of cerebrospinal fluid is 1.003. Here we can see that the hyperbaric solution is more dense than CSF. To make the solution hypobaric, the density of hypobaric bupivacaine is 0.9993. CSF and local anesthetic density change with temperature. Plain bupivacaine 0.5% at 24 degrees Celsius is isobaric, and the same solution at 37 degrees Celsius is hypobaric. By increasing the temperature, the density of the solution decreases. Thus, a small volume of a drug at room temperature, which is injected intrathecally, quickly equilibrates after injection and increases to the temperature of the CSF, becoming hypobaric. Clinical importance of baricity. The clinical importance of baricity is the ability to influence the distribution of local anesthetic spread based on gravity. Hyperbaric solutions will preferentially spread to the dependent regions of the spinal canal. Hypobaric solutions will spread to the non-dependent regions, whereas isobaric solutions tend not to be influenced by the gravitational forces. This is a video of a glass spine model of local anesthetic baricity. This is a glass spine model showing various cervical, thoracic, lumbar, and sacral vertebral levels. When two solutions, one isobaric, one hyperbaric solutions injected intrathecally at the lumbar vertebral level, The hyperbaric solution tends to spread more towards the gravitational forces, especially the sacral regions, whereas the isobaric solutions is not influenced by gravity. Thank you. Thank you, everyone.
Hello. By the time Richa madam arrives, just one correction, Geethavarshini.
Yes, sir.
You mentioned specific gravity, some units. There are
Yes.
no units for specific gravity and baricity. They are both comparative ratios. There is no unit. So please correct that.
Yes, sir.
Okay.
Thank you, sir. Sorry, actually, connection was lost. So, hello.
Yes, ma'am.
Yeah, sorry. In between, my connection was lost actually. So I think yours is finished. Hello, sir.
Yes, ma'am. We can hear you, ma'am.
You continue, please.
She has finished her
Hello.
lecture. You can
Okay,
ask
sir.
Dr.
Okay,
Shirish
sir.
to.
Actually, sir. Okay, sir. Sorry for the disturbance. And now I am calling Dr. Shirish to give his valuable talk on the safety concerns which is needed for the segmental spinal anesthesia. Dr. Shirish, please join us.
Hello. Hello. Is my screen visible?
Yes,
Yeah,
sir.
yeah, it is.
First of all,
Visible.
myself, Dr. Shirish. First of all, I am very much thankful to Dr. Meenakshi Sundaram, Dr. Paliwal sir, and moderator Richa madam to giving me this opportunity to present on this topic. So today I'm going to discuss about safety concerns in segmental anesthesia. So what is segmental anesthesia? Is the introduction of spinal needle at desired level with aim to produce targeted segmental block using relatively small amount of drug. With increasing popularity of this new method, safety concerns are very much important. So we are basically discussing neurological injuries, hemodynamic fluctuations, ventilatory impairment, a level of anesthesia, and medical legal issues. Moving to neurological injuries. It's proven using various myelography and MRI studies that at thoracic level, the spinal cord is placed more anteriorly, leaving sufficient space between posterior dura and spinal cord. As you can see, this is a sagittal section of whole spine. In this image, you can see that the spinal cord is placed very much anteriorly at thoracic kyphosis level. And the maximum distance is around T5 to T6 level. And one minute.
Hello, sir.
Uh,
So now we cannot hear you. Hello. Hello.
hello. Hello.
Yeah, Dr. Shirish. Yeah, yeah. Voice was interrupted actually. Now it is okay.
Okay.
Please continue. Yeah.
Okay. 1 minute, madam. Actually, I have lost my screen.
No worries. Uh, so has it started or not?
1 minute, ma'am. I'm trying.
Okay, Dr. Mahure was talking about the concern why we are not getting the neurological injury at mid-thoracic or the lower thoracic one, which are always away from the conventional lumbar and spinal anesthesia.
Yeah.
Now I think it
Hello.
has started. Yeah.
Hello.
Please start.
Yeah. So the distance at T, extremely sorry for the interruption. The distance at T5 and T6 level is 6.17 millimeter, and which is maximum, and it is very much less at upper thoracic and lower thoracic levels. Lee, R.A. et al. Studied anatomy of thoracic spinal canal at different positions, that is supine, lateral, and sitting positions. With MRI studies, what he found, the distance at mid-thoracic level are maximum in all the three positions. And fortunately, it is maximum in sitting position, that is 5.95 millimeter. Fortunately, which is the best preferred position for all of us to give spinal anesthesia. This is the diagrammatic representation of the same thing. This is the axial view of spine, at thoracic and lumbar and caudal level, where you can appreciate the spinal cord is placed very much anteriorly, and there is sufficient space in between posterior dura and spinal cord at thoracic level, which is very less in lumbar area. So if you see at mid-thoracic segment, the spinous processes are angled, very much angled. And if you try to enter and puncture dura, you have to go with around almost 40 to 45 degrees of angle. And if you compare it with lower thoracic and lumbar levels, the angle is very less, that is 9 to 10 degrees. So you have to go almost perpendicularly, which give you added advantage of you have more space to travel between cord and dura, which give you additional benefit. Recently, in April 25, American Journal of Neuroradiology has published a good research article of low incidence of neurological complications during thoracic epidurals with anatomical explanation. They have stressed same things, that spinal cord is placed more anteriorly, and there is sufficient space between cord and posterior dura, along with angle. We have to go with angle of 40 to 45 degrees. So it gives more space to needle tip to travel. Routinely, what we are doing clinically, deciding the space, which is not an accurate method. Inadvertently, we are giving spinal at a level or two higher in obese, elderly, and parturient patients. Only it has found that 29 to 40% of anesthesiologists entering a desired level, that is L3, L4. There is also anatomical variation and inconsistent termination of levels at the spinal cord level. So, and we are doing routinely thoracic epidurals since long time. So we have observed that neurological injuries are less because of all the factors which I have discussed. Moving to bradycardia and hypotension, that is hemodynamic fluctuations during thoracic segmental spinal. For that, there are three basic reflexes of heart, that is Bainbridge reflexes, carotid baroreceptor, and distal gyrus. Out of these, Bainbridge and carotid baroreceptors reflex are stretch receptor and pressure receptor dependent reflexes. These are all preventive reflexes for the safety of patients. In both of these reflexes, they are if the volume of blood is increased and stretch receptors which are present in right atrium and pulmonary artery get stretched, it sends signals through afferents to the medulla, which in turn sends afferents via cardioaccelerator fiber, that is T1 to T4, to increase the heart rate, and ultimately which decreases the volume load. Same with carotid baroreceptor, that are pressure receptors situated in carotid body and arch of aorta, senses pressure, and ultimately if there is hypotension, it sends responses with sympathetic stimulation, which ultimately increases heart rate, and vice versa. If you compare the two scenarios, spinal anesthesia with hyperbaric solution and level is ascending above T4 level, that is cardioaccelerator fibers are getting paralyzed, and there is profound vasodilatation in lower limbs leading to hypotension, and these reflexes are get blunted. So there is no compensatory tachycardia, which may leads to the persistent hypotension, bradycardia, may ultimately land up in a systole. If you compare same scenario with isobaric solution of very small amount, small volume, so the bradycardia and hypotension may occur in thoracic segmental spinal, but it transient because of block of the cardiac accelerator fiber. Why? Because there is a lumbocyclar sparing and less vasodilation in lower limbs, which helps to maintain right atrial pressure that sustains outflow from intrinsic chronotropic receptor to maintain heart rate. Also, the CSF volume in thoracic spine is very less, so we can achieve the desired segments with very minimal dose to avoid these hemodynamic fluctuations. Moving to ventilatory impairment, the main muscle of respiration is diaphragm, which is usually unaffected. Expiration at rest is passive process. However, forceful expiration and coughing may get affected because of paralysis of the anterior abdominal wall muscles. However, the low doses of drug used for segmental spinal preserves the coughing ability by causing minimal motor weakness of expiratory accessory muscles. The level of anesthesia, isobaric drugs are less sensitive to position issues. Thoracic nerves roots are thin and amount of CSM in thoracic area is very much less. So very low dose of drug is required to achieve desired level of anesthesia. They have propensity to block sensory nerves in preference to the motor one. So chances of high total spinal is very less. I have taken screenshot from the same video played by Dr. Geethavarshini. You can see the puddle form after isobaric solution is very less, almost 2 segments, and if we compare 2 segments above and 2 segments below as compared to hyperbaric solution, which moves to the dependent part. Moving to the last concern, last but not the least, medical legal concerns. In 2022, an original article was published where litigations related to anesthesia analysis of claims against the NHS England during year of 2007-8 and 2017-18 and comparison against previous claims of patterns. What they have found, this data is about lumbar spinal anesthesia with hyperbaric solution, not about thoracic segmental or isobaric drug. What they have found, the litigations are very much high towards regional anesthesia, which tends to decrease in recent decade in 2017-18, but still they are on higher side compared to other litigations. So litigations are bound to happen, and they are even can happen with routine hyperbaric solutions. So recently, a BJA has published defining the role of thoracic spinal anesthesia in 21st century, a narrative review, which they have mentioned in conclusion. The main rationale of supporting its use is to avoid subjecting high-risk patient to general anesthesia while still providing a safe and effective anesthesia. Despite the absence of larger trials, evidence from small cohort studies and multiple case reports that thoracic spinal anesthesia may be considered a safe, feasible, effective alternative of anesthesia technique and may be used as in a patient where other anesthesia techniques possess higher risk. So theoretically, incidence of neurological injury after accidental dural puncture during thoracic spinal is less but may occur. Spinal cord or spinal nerve injuries are potentially disastrous complications. Many cohort studies, case series, papers were published stating safety of segmental spinal in indicated patients. Still, references are not present in standard textbook, but which all evidence is present, we can stand in court of law for indicated cases. Thank you very much.
Thank you, Dr. Shirish, for the nice presentation. I just want to add 2 things because you told it. Like first is MRI studies. We have already done it in Indian population. And at T5, we got around 1 centimeter. It is published, and 1 centimeter at T5 I got. Because before starting, I did MRI studies in Indian population because we are catering the maximum population of the world. That's why I did this. And secondly, you quoted this BJ article, and this doses of this BJ article was challenged by Dr. Paliwal sir. and they accepted all the doses which were suggested by Dr. Paliwal sir. So if anyone who is following that BJ article, please don't follow that. Okay.
Okay.
So yeah. So now I'm going to ask for the practical tips from our father of segmental spinal anesthesia, Dr. Naresh Paliwal. We used to say him like this because he is patron of our society, Neuraxial Anesthesia Development Society. So now I am calling sir, please share your experience, practical tips before starting segmental spinal anesthesia.
Okay. Shirish, please stop your screen sharing so that I can share my screen.
Yeah, sir.
So, good evening, everyone. Thanks to Dr. Meenakshi Sundaram and all the organizing team, moderator Dr. Richa, my colleague Dr. Shirish, and Geethavarshini, who explained about the baricity and all. Without wasting much time, I'll move on to my practical aspects. Most of the things which are covered and they are in my presentation, well, I'll skip them during my presentation. So, we have recent development of a Neuraxial Anesthesia Development Society, and Dr. Richa is the secretary of that. Now, segmental spinal is not a new technique. It's a old technique. The way it actually became a red hot topic during COVID, everyone knows that. And the way it's going, it looks to have a bright blue future. Now, about this article in BJ, it was in April 2022, and the chart they published had some fallacies in that chart, and I conveyed to the editor, and they have accepted about the fallacies, and they are about to publish the corrected chart in the next this thing. In the same BJ, there was an article about the use of thoracic spinal for thoracic surgeries. And given the trajectory of thoracic surgery and anesthesia, it holds promise to form part of thoracic anesthesiologist's armamentarium in the future. And I'm happy to share that my article is also accepted in BJ, and it will be published within 2-3 days. Now, in short, about what is segmental spinal, it is actually covered by the while the introduction, the term often used synonymously with thoracic spinal, but often the low doses of drug used at a higher lumbar level can produce a segmental effect. So it is actually blocking the required dermatomes with a very low volume of local anesthetic injected near the targeted nerve roots. Lower the dose, more likely to produce a true segmental block. Some factors which make segmental spinal feasible at thoracic level: the spinal cord is positioned anteriorly. As already you have seen the MRI images, nerve roots light and thin. Amount of CSF is comparatively less. No difference in the onset time for isobaric and hyperbaric drugs at thoracic levels. While the isobaric drugs may take a little longer time for onset at lumbar levels. Now, Shirish has covered all this, so I will skip this. Only the relevant images, if they are not presented, I'll talk about that. Here, the spinal cord sits ventral in the apex of the thoracic curve. When you ask the patient to flex the spine, it goes more ventrally. This everything has been covered. The similar thing is true in pediatric patients also, but the pediatric segmental spinal is still in infancy, and we have recently published an article on case series on pediatric segmental spinal anesthesia. Now, one more thing about the safety. Can you identify a safe interspace in such patients? You're always 1 or 2 spaces higher than what you intend to, especially in obese and parturients. What that means is you're already going for a high lumbar or low thoracic spaces unintentionally in your practice. So that proves about the safety of segmental spinal again. Again, this is one picture where you can see by palpation, when you palpate, you're not always correct. You're not always palpating correctly the L4-5 or L3-4 space. You're always 1 or 2 spaces higher than what you intend to. It was confirmed with ultrasound. The position of conus medullaris is also variable. These things are all covered. Now, feasibility of segmental spinal and indications. Feasibility, there are 4 aspects: technical, economic, legal, and operational. Technically, it's not very difficult and different from your routine lumbar spinal, especially at the low thoracic levels. Only at the mid thoracic level, it is slightly difficult. Economic, it's very, very economic as compared to other modes of anesthesia. Legal, still a question mark, but can be defended with strong indications. Operational, it can be operational at any setup with basic minimum facilities. About the indications, all intra-abdominal surgeries, all, be it open, lap, major, minor, upper, lower, they all can be done in segmental spinal. Even the breast, superficial thoracic surgeries, NEVATs, bulectomy, thymectomy, lung volume reduction, anterior mediastinal masses, even the prone lateral position, musculoskeletal, urological, gynecological surgeries. The only thing is indication of segmental spinal needs to match the surgical needs of the patient. Advantages for routine spinal or at times for general anesthesia. The surgeries which were thought to be out of domain of spinal anesthesia, like upper abdominal, thoracic, and breast surgeries, are possible under segmental spinal. A higher levels of the block can be achieved with just half the dose than that is required at lumbar levels. There is minimal hemodynamic fluctuations, early recovery, and voiding. Special advantages for general anesthesia and patients with respiratory comorbidities. And also there is less postoperative pain and post-op nausea, vomiting. Cons and remarks: as we all know, spinal cord damage is a potentially disastrous complication of dural puncture for any reason that can happen even in lumbar. Fact that anesthetic technique is not usual does not mean that it's wrong. Concept has developed that regional anesthesia should need no supplements, and if it does, it should be considered a failed block. This reasoning needs rethinking. And finally, the patient safety takes precedence over the unnecessary risks to be taken for success of the procedure. Now, there are 3 different modes of using segmental spinal. Either it can be a single shot spinal for short to mid duration surgeries of 90 to 120 minutes, or it can be combined with epidurals. Here, the epidural can be handy, especially in a very morbid ill patients where you want to use a very low dose in segmental spinal. There, epidural can be handy not only as a backup, but also by epidural volume extension technique. You can spread the low doses used intrathecally to wider segments. And also, epidural is useful for post-op analgesia. The third option, just like your continuous spinal anesthesia, there is continuous segmental spinal anesthesia by putting catheter at the thoracic levels. Drug options, either isobaric or hyperbaric drugs alone can be used, or a combination of either of 2 from the 3, that is isobaric, hyperbaric, or hypobaric, can be used. In general, the isobaric drugs are preferred for laparoscopic, thoracoscopic, breast, and intra-abdominal surgeries in morbidly frail patients where relaxation is not an issue. Hyperbaric drugs can be a choice for open surgeries, especially where you want a good amount of relaxation in male muscular patients. In those, hyperbaric drugs can be a choice. Hyperbaric drugs are low concentration, high volume, little unpredictable. So they are not used alone unless it is very superficial surgery, but they can be used in combination with other 2 for desired effect. Isobaric drugs advantages: they are less sensitive to position issues. In low doses, as already mentioned, they have propensity for a sensory block. Onset is gradual. There is hemodynamic stability, early ambulation, voiding. Spinal can be given directly in the operative position, or you can give spinal in any position and patient can turn on his own to the desired position. Suppose you want to do a prone position surgery, give spinal in any position, lateral, sitting, or even prone, and the patient can turn on his own because it takes a little time for onset, and there is no worry about the drug being spread with gravity. So you can use in any position. And the spinal can be given before epidural. What happens when you use hyperbaric drugs? You need to put an epidural first and then spinal. But here you can give spinal first and then epidural. Disadvantages of isobaric drugs: levels of block cannot be modified by any change of position. You need to put a proper drug at proper site. There can be sacral sparing when low doses at higher spaces are used. This can be an advantage for upper abdominal surgeries, but can be a little disadvantage for abdominopelvic surgeries. Then you have to use slightly more doses to have these lumbosacral roots covered. There is longer onset time at lumbar levels, less muscle relaxation. They are sensitive to temperature variations. This was a question asked in chat box. And they are sensitive to temperature variations. It can become little hypobaric when warmed at 37 degrees centigrade, or can become slightly hyperbaric when cooled at 24 degrees centigrade. Amongst the available drug options and additives, isobaric drugs, we have bupivacaine 0.5%, bupivacaine 0.5%, and ropivacaine 0.5-0.75%. Chlorprocaine 1% was isobaric drug, which is not available nowadays. It was a very good drug for short cases of 40 to 60 minutes. Amongst the hyperbaric drug, till date only bupivacaine 0.5% was available, but now levobupivacaine and ropivacaine 0.75% are available. Additives, there are n number of additives, opioids, then alpha-2 agonists and all. But for a better profile of this segmental spinal, what we use is a fentanyl for short to mid-duration surgeries, around 20-25 micrograms. Dexmed is a very good additive. It is all-in-one drug actually. It has a propensity to prolong the duration in a dose-dependent manner, and also the side effects are dose-dependent. Ketamine, though potentiating sensory block, is known to shorten the motor block time, and clonidine can be used when Dexmed is not available. How to decide about the dose and the site of injection? In general, 1 ml of the isobaric drug spreads 2 to 3 segments above and below the site of injection. What that means is 2 to 2.5 ml of the drug can block segments from T2 to L5S1 when spinal is given at around T10. 10 thoracic space lying in the center of the surgical field for upper abdominal surgeries. Dose of local anesthetic, additive, and the site of injection can be varied according to need. For breast and superficial thoracic surgeries, spinal can be given at mid-thoracic levels T4-5-6 and a dose of 1.2 to 1.3 ml maximum. 1.5 including additive is enough. Duration it can provide is 60 to 90 minutes or slightly more duration when Dexmed is used as additive. Can be combined with epidural or sominterfacial plain blocks for longer duration surgeries. Nowadays, we combine it with erector spinae plain block, unilateral erector spinae plain block for MRM surgeries. These are the different levels required for different types of breast surgeries. Like for MRM, you need C5T7, mastectomy with transverse rectus abdominis flap, C5 to L1. Partial mastectomy, breast augmentation, just T1 to T7. The epidural scoring scale for arm movements, which is used to assess the motor blockade during thoracic epidurals, can very well be used to assess the motor blockade during thoracic spinal. There are 4 grades, 0 to 3. C8, T1 is a hand grip, C7, C8 is the wrist flexion, elbow flexion, C5, C6. And this was a chart which I have prepared about the surgical procedure, level of injection, drug dose, volume, and concentration, different levels achieved, and additional blocks you need for post-op analgesia. So this was presented to BJA for in correction of that chart in that article. In short, about the pediatric segmental spinal, this is still in infancy. I'll not go into detail about this because we don't advocate to try this pediatric segmental spinal unless you are well versed with the other aspects of pediatric spinal anesthesia. So I'll just move on. This was again the chart which was prepared by me about the different doses in pediatric spinal anesthesia for lumbar spinal. Dose in milligrams per ml, dose in ml per kg, milligrams per kg, ml per kg in different age groups, and then the modified scale, Neuroaxial Anesthesia Development Society scale for segmental spinal. So I'll just skip this. Now, position of the patient walking spinal. Using isobaric drugs, you can give in any position. You need not worry about the gravity-dependent spread. So you can give spinal either in lateral sitting or even in prone positions. Plain bupivacaine, levobupivacaine, ropivacaine are slightly hypobaric, and addition of fentanyl, which has a density of around 99360, makes it slightly more hypobaric. So if you keep the patient seated for some time after giving spinal, there are chances that high levels may be achieved. So you have to keep this in mind. Addition of fentanyl can make these drugs a little more hypobaric. Using 2 drug combinations, sitting position is mandatory for giving spinal. I'll come to that later. Type of the spinal needle. If you are combining with epidural, CAC kit can be the easiest and safest option. You can have added safety with CAC kit. Either Quincke or pencil point needle can be used. There are reports about the more chances of paresthesia with pencil point needles, as you have to enter around 2 millimeters more in the intrathecal space with pencil point needles. But this is just theoretical. About the landmarks to identify intervertebral spaces, you can find from the approximate surface marking. You know vertebral prominence as C7, root of the spine of the scapula about T3, inferior angle of the scapula T7, and then your superior aspect of iliac interfacial margin, this. Then if you have ultrasound, you can take the help of ultrasound, count upwards from the L5S1 in parasagittal oblique view, or you can mark the 12th rib, go upwards. You can identify the first rib and go downwards to locate the required interspace. There are some anatomical hurdles for thoracic spinal. The spinous process of T4 to T9 are sharply angled. The spinous processes are not always in straight line. They are undulating, and there are lateral angulations as well, because there is one more lateral curvature in the thoracic spine, which most of us don't actually appreciate. But because of that, there are some lateral angulations and undulating spinous processes. There is very narrow interlaminar spaces at mid-thoracic levels. These are difficult to approach with a midline approach, so either a paraspinous or a paramedian approach can be helpful. Anatomy at the upper thorax, it's not very important for us in context to the segmental spinal. We hardly go about T4 for giving spinal. These are just like your lower thoracic levels. The anatomy at the mid-thoracic levels is important for us because the spinous processes are very steeply angulated. There is very narrow interlaminar space. And the things which you have to keep in mind about this is the transverse process. The lower margin of the transverse process usually corresponds with the safe landing spot or the mid lamini, and the upper margin of the transverse process usually corresponds with the interlaminar space. So if you can identify the transverse process with ultrasound, you can have an idea where the interlaminar space can be. Also the interfacet joints, you can very well identify ultrasound, and you can locate the interlaminar space. Now, this is illustration of how lateral to midline entry with some upward inward angulation can open up the interlaminar space. This is just an imaginary process. Just imagine that the needle tip has an eye or a camera on it. In the first image, you can hardly see any interlaminar space is open. Just imagine that the needle tip has an eye or camera. When you go perpendicular to the upper margin of the spinous process, just 1 to 1.5 centimeters laterally, hit the mid lamini, and then turn the hub of the needles around a centimeter down to create an angle of 60 degrees. You can see in the next image, in the middle image, the interlaminar space has slightly opened up. And when you turn the hub of the needles around 5 millimeters laterally in the third image to create an 15 degrees inward angulation, that has actually opened up the interlaminar space. This is just imaginary. A paramedian approach for thoracic spinal, as I already mentioned, you have to go from the upper margin of the lower spinous process around 1 to 1.5 centimeters lateral, go perpendicular in all directions, hit the lamini, that is called as a safe landing spot. And from there, and upward and inward angulation, step by step, you have to enter the interlaminar space. Because it is very difficult with the midline approach, you have to use a paramedian approach or a paraspinous approach. So in scoliotic spine, you need to know where the spinous processes are actually turned, and where the body of the vertebrae is turned is usually the convex side, and where the spinous processes are turned is usually the concave side. The convex side of the scoliosis is more open for going to approach the interlaminar space. If you want to approach by a midline approach, you have to go towards the convexity, as can be seen in the first image. You need to go towards the convexity, or by the paramedian approach, you go from the convex side. Otherwise, if you go from the concave side, you may not be able to reach the interlaminar space. This is just to demonstrate just what I was talking just now. In the midline approach, go towards the convexity. In the paramedian approach, go from the convex side. The red arrows can show this thing. This is a paraspinous approach. When you go just 0.5 to 1 centimeter or even less than that alongside the spinous process, I'll just show a video of this. The angle of median angulation should not be more than 5 to 10 degrees, just alongside the spinous processes. This is many times happens when you think you are in the midline approach, the needle skips through your interspinous ligament and finally you end up in a paraspinous approach. The angle should not be more than 5 to 10 degrees. Otherwise, what will happen is you may end up going towards the opposite side paravertebral space or even intercostal, this pleural space. This is for lateral position paraspinous approach. What you can do is just you palpate your knuckles like that. You can palpate the lower margin of the spinous process. Just from the upper margin of the lower spinous process, you can go by a paraspinous approach. A little careful at and median angulation, you can approach the interlaminar space. Ultrasound imaging of the thoracic spine. T10 to T12 are similar to lumbar vertebrae. T4 to T9 are steeply angled spinous processes. Very small window of the parasagittal oblique view. There is no window in the transverse view. This is how you can do ultrasound in the transverse view, parasagittal, in the sagittal plane, parasagittal oblique view. You can mark the midline, mark the depth to the interlaminar space. You can see the posterior complex, anterior complex. This is how it looks in the parasagittal oblique interlaminar view at the thoracic spine. The laminae are flat leaf-like as compared to the sawtooth or the horse-head appearance at lumbar levels. They are flat leaf-like, and the posterior complex, anterior complex is very, not easily seen. But if you are able to see the anterior complex very clearly through this interlaminar space, that space is supposed to be open for giving your either epidural or spinal anesthesia. This is how it looks in the transverse view at the thoracic spine. It's hardly of any use apart from knowing whether there is any scoliotic or lateral deformities. This is when you use a USG guided paramedian approach. This is another paramedian X view, which has been used for giving USG guided epidural and spinal. There are some safety measures for successful use of secondary spinal. You need to do a thorough preoperative assessment. What are the dermatomes that will be involved in that particular surgery? If ultrasound is available, you can do a pre-procedure scanning. Identify the landmarks, selection of the proper drug, dose, site, and mode of secondary spinal. After giving spinal, you need to assess the levels, monitoring, and proper sedation. I'll skip this, my segmental spinal profile. Now, 50% of my SAB profile is my segmental spinal. I usually do a complete pre-anesthetic evaluation, emergency airway cart, venous access, no sedative pre-medications. Spinal, I usually prefer lateral position, 27 gauge needle. Drug dose, site mode according to patient and surgery. For intra-abdominal surgery, for short duration surgeries, I used to prefer chlorprocaine, but it's not available nowadays. So I either use isobaric levobuprocaine, buprocaine, or ropivacaine according to need. For mid-duration surgeries, 60 to 120 minutes, either isobaric or hyperbaric with additives. Average female patient is a 1-2, you can use 2 ml plus additive. Average male patient, 2.5 ml plus additive, around T10 level for all intra-abdominal surgeries. And usually I combine this with some interfacial plane block, tab block, rectus block, erectospiny plane block as per need, or local anesthesia at the port site for laparoscopic surgeries. For breast surgeries, I have already told about this, combined with epidural or some PEG block, serratus anterior plane block, erectospiny plane block for post-op analgesia. Two-drug technique, the combination of any two, iso, hyper, or hypobaric. Now, what happens when you want to do some abdominopelvic surgeries, and if you want to use a very low dose in segmental spinal, then there is some lumbosacral sparing, and patient can feel pain during pelvic manipulations, like for patients with TLH, PCNL, where you want to have a dense block at lumbosacral roots also. In those cases, you can combine a very low dose of hyperbaric I mean, combined means in the separate syringes, you can use just 0.5 to 1 ml of hyperbaric initially in sitting position. And in different syringes, you can add around 1, 1.2, 1.5 to 2 ml of isobaric drug according to need with some additive around T10 space. So this is about hyperbaric with isobaric for some abdominopelvic surgeries. The another combination is hypobaric with isobaric drugs. Now for laparoscopic cholecystectomy, the position kept is head up position. So you can take the advantage of that position and you can have a combination of hypobaric and isobaric drugs to achieve a desired higher levels up to cervical roots so that the patient does not have any shoulder tip pain. After giving segmental spinal, patient turn to desired operative position. There can be sensory block tested within sets in 3 to 4 minutes. There's minimal gradual hemodynamic fluctuations, usually within the first 10 minutes. No respiratory issues even with high levels of block because mostly it is a sensory block. Initial partial involvement of the sacral roots can be seen as per the depending on the dose you have used in the segmental spinal. No additional supplements if levels are adequate. Usually don't require any additional supplements, but patient can be completely mobilized in 4 to 6 hours. To sum up, it's a very useful technique with many advantages, minimal risk with due precautions. No need to panic even if the block level is found to be higher than desired. Lap surgeries may need little sedation. If available, ultrasound can be helpful for more safety. Technique is reserved for experienced clinicians with good learning curve. I hope I am not exceeding the time limit. Is there any time?
Sir, it was half an hour. Otherwise, you will be having the same questions. I think you should continue your thing.
Just 10-15 minutes. I'll
Okay,
cover
sir.
the videos
Otherwise,
and
we'll ask
everything.
the same questions from you.
Okay. If there is time, I
Okay.
will continue just some videos and some little. Okay. Now, some comparison between the segmental epidural and segmental spinal. Both the things are quite similar. They produce segmental block with minimal hemodynamic changes. Injection site is most important in the both. Should be in the middle of the dermatomes. Concentration of drug affects the density of block in both. Lower the concentration, more differential the block is in segmental epidural as well as segmental spinal. But there are some positives about segmental spinal as compared to segmental epidural. It's economic, it's quick. There is definitely an end point in the form of free flow of CSF. Drug required is just 1/10 of what is required in segmental epidurals. And it also does not have any patchy effect or some issues, just in case there is some previous poliotic deformities or some previous surgery. In epidurals, you can have some patchy effects. And as the drug used is very less, the chances of blast are minimal. The only disadvantage of segmental spinal as compared to epidural is no versatility to extend the levels or duration of block and cannot be used for post-op analgesia. Now, this again, I'll skip. Just a minute. I'll come to the important part of do's and don'ts, which was again recently published in IJA, this portion. About the do's, before proceeding, know in detail about the technique. What are the various drugs that can be used? What are the different drugs that are available with you? What are the different doses, additives, and site of injection? You should know in detail about your surgeon. If you're not accustomed to working with him or you have not worked with him, you should know how adaptable your surgeon is to the changed conditions, how flexible your surgeon is, how is he going to listen to your requests about keep the initial IAP and initial flow rate to minimum, how efficient your surgeon is, because many surgeons, they take just 10-15 minutes for lap poly, many take 1 hour, many take 2 hours. So you can choose your mode of segmental spinal according to your surgeon, patient, surgeon, and the duration required. About the surgery, open lap, duration extend, and about the patient also, how cooperative your patient is, and is he willing for a sole regional or not, comorbidities, risk-benefit ratio of GA versus segmental spinal. Then use the position which you are accustomed to as a sitting lateral, unless there is specific recommendation. Do a pre-procedure ultrasound scan if it is available. CSC kit if you want to combine with epidurals. Do always use multimodal analgesia or segmental spinal to have a better profile of segmental spinal. The multimodal analgesia should be in the form which will avoid post-op nausea, vomiting, and respiratory depression. So I usually use dexamethasone, diclofenac, paracetamol, and avoid the drugs which will cause post-op respiratory depression and nausea, vomiting. Do prepare and keep ready your backup plan as always. About don'ts, don't force your surgeon to do it under segmental spinal unless there is a strong indication. Don't be rough and rusty, advance gently, millimeter by millimeter. In case you elicit any paresthesia, just withdraw the needle and change the direction. Don't use higher doses of local anesthesia at mid or high thoracic spaces. The dictum is use higher the space, lower the dose. Lower the space, you can increase your dose. Don't unnecessarily add too many additives together just because someone is using 2-3 additives together. Unless you are well versed with their behavior intrathecally, just keep it simple. Just use one single additive for short to mid duration surgery. Don't use excessive sedation with higher levels of block. With block extending to the upper thoracic and cervical regions, if you use excessive sedation, that may change the respiratory pattern and may be disturbing to the surgeon. Unless you are combining it with some supraglottic airway devices, don't use excessive sedation. Don't panic with early hemodynamic respiratory issues. They are minimal, gradual, and easily manageable. Though it's possible to do even thyroid and upper extremity surgeries under segmental spinal, it is not recommended to use this technique for such type of procedures as there are more safe and less invasive blocks available for these surgeries. And also I want to stress that don't use it as an overkill, because I have seen people using it for even simple fibroadenomas. So better not to use it unless there is a strong indication, unless you get a confidence to use it in your routine practice. Don't use it in pediatric patients unless you are well versed with other aspects of pediatric anesthesia. Don't hesitate to call for help or communicate in case of any doubts. Future prospects. Now everyone knows AR, VR. Now the AI can be very helpful. Then AI-based support system can identify most suitable cases. AI models can help predicting likely adverse events, complications based on patient data. AI algorithms can help calculating optimal doses. AI-driven monitoring systems can be helpful for analyzing real-time patient data and taking timely decisions. Future prospects, there can be AI-guided segmental spinal. Now I'll just in short show you some videos how straightforward and simple it is at the low thoracic level. This is a patient of some umbilical or epigastric hernia. Lower thoracic space is used. There is not as much of angulation. Spinal is being given by 27 gauge needle. And that's all. There is not as much of angulation at lower thoracic level. It's very simple. This is 130 kg lady with a epigastric hernia, and we did a pre-procedure scan. Our second-year resident was giving this. I'm showing this video in detail just to have an idea how gently you have to go step by step, removing the stellate of the needle at every loss of resistance. No harm in taking some time. This is by pyramidine approach. She is giving spinal. The other videos I will just show in short. This is important, that's why I'm showing in detail. Just go step by step, removing the stellate at every loss of resistance. Now I think she has done. This is lab coli with CTCO2 monitoring in the patient with diabetes, hypertension, ISD. Patient is conscious. 60 years male patient. This is a very old case, around some 7-8 years back, when I used to do MRM under combined segmental spinal epidural. Epidural T45, spinal T56. You can see the comfortable patient is even with such high levels of block. There was no sensation at C8, but her grip strength was good, indicating only a sensory block. This is a traumatic diaphragmatic hernia done somewhere around 2018. It was done under combined segmental spinal and epidural. Here the spinal was given first and then epidural was put in lateral position. You can see whole of the left hemithorax was filled with the intestine. Diaphragmatic mesh repair is being done. The same patient at the end of surgery is comfortably, and next day X-ray of the same patient. This was 6 days old jejunal perforation. I done it recently, some 3-4 months back. 55 years old male, segmental spinal, 2.5 ml hyperbaric drug because there was guarding rigidity present. So wanted to have relaxation. You can see very old perforation. This was a huge obstructed umbilical hernia. Again, combined segmental spinal and epidural. There's a huge ovarian cyst done with 2-drug technique, 0.5 ml hyperbaric and 2 ml isobaric technique. Around T11-12 level in sitting position, T12-L1 level. Cyst was such big that it had to be ruptured in spite of the full length incision. Cystectomy, omentectomy, hysterectomy, everything was done. This is 2-drug technique for lap chole. 2 ml of 0.15% hypobaric bupivacaine and 1.5 ml of isobaric bupivacaine plus 20 micrograms of fentanyl at T10. So after that, we have started using just 0.1% because this patient had some discomfort, respiratory discomfort, even with just 0.15%. So nowadays, what we do is we use just 0.1% of hypobaric drug. Levels tested were up to the cervical roots. This is NEVAT, segmental spinal, just 1.2 ml UVP, and T56, erector spiny plane block, massive pleural effusion for thoracoscopy and pleurodis. This is again MRM. These are same patient shifting herself at the end of surgery. TLH with 2-drug techniques, spinal at T11-12, 0.5 ml hyperbaric and 2 ml isobaric. CA vocal cord post-cricoid occlusion for feeding gastrostomy. Is a very morbid old patient. Just 1.5 ml at T8-9. This is acute ruptured ectopic. Here I used chlorprocaine because the surgical time was not more than 60 minutes. I had done more than 30-40 cases of ruptured ectopic under segmental spinal. See the whole of our abdomen filled with blood. This was a patient of TLH, a relative of a doctor, who was having atlantoaxial dislocation with vessel invasion. C1, C2 fixation was done and there were diffuse disc bulges of C5-6. She was very much worried about her neck movement. She used to get giddiness. And I gave her the option of segmental spinal. She happily accepted and it was done under segmental spinal. Ruptured liver abscess, hemoglobin just 4.9, CRP was raised, creatinine 1.27. This is how usually I monitor ETCO2 by attaching a 12-gauge Nelcat tip to a ETCO2 probe. If there are special probes available, then there is no issue. This is simple appendicectomy. This is mother of a doctor for hysteroscopic removal of a polyp. 1 hour after the procedure and 3.5 hours after the procedure, she is ready to go home. This was a patient who was accidentally extubated during his previous surgery during lap chole. It was a very difficult intubation, somehow intubated, and then someone thought that the tube is not inside, it was accidentally extubated. And next time when he came, I convinced him for laparoscopic cholecystectomy under segmental, and he is watching his own surgery. This is male MRM. Erector spiny plane block first, then segmental spinal. This is again MRM, hypertensive degenerative heart disease, erectospiny, and patient going to bathroom after 3.5 to 4 hours with assistance. These are some pediatric cases. 12 years old female patient, twisted ovarian cyst. According to my formula, it's just 1.5 ml plus 20 microgram fentanyl with 27 gauge needle. She was a cooperative child, nothing needed before spinal with ETCO2 monitoring. Patient is shifting herself at the end of surgery. This is again small kit appendix, laparoscopic appendicectomy.